Dr. Nalini also participated in adolescent health projects for girls. She was a consultant in an international program to reduce neonatal mortality in Mahbubnagar. Welcome, Dr. Nalini. Going over to Dr. Suhas, who's a consultant physician, consultant pediatrician from KMC Manipal, working at Yashoda Hospital and Hazel Tree, Mother and Child Care, Gulbarga since 3 years. You will see him in the spotlight. Don't go by his age. He has got a lot of wisdom with him. So welcome, Dr. Suhas. And my co-moderator, Dr. Kulkarni, Dr. Vinayak Kulkarni. Both of us studied from Gandhi Medical College, Bhopal. He's done his MD Pediatrics and was also a senior resident at St. Stephen's in New Delhi. Worked for Libya for 3 years. Currently, for the past 33 years, he is running a hospital in Children's Hospital in Yavatmal in Maharashtra. Welcome, Dr. Kulkarni.
Thank you.
So with this brief introduction, we go over to Dr. Nalini. And
thank you very much, Dr. Kamlesh and the CPD, AFPI CPD group for giving me and Telangana chapter a chance to present on COVID-19 in children for family physicians. As you know, the second wave has been creating panic among the people as well as the doctors, and because this is a learning experience, every day we are learning new things, as Dr. Kamlesh has already mentioned, because what all we learned in the first wave has changed in the second wave, and even the incidents, like more younger adults and children are being infected, so that is causing concern. And so we are trying to search for causes of these new mutants and all these things. So as we know, COVID-19 is a disease caused by a new strain of coronavirus called SARS-CoV-2. And the reason for the surge in cases is not only the new mutants, but also the lack of guard and the complete unlock and large gatherings and all. And we have seen that lockdowns have brought down the cases significantly during this last week. And incidents that is worrying us is the young adults getting infected, because less than 20-year-old, more than 12% are being infected, and the mortality rate has been 3%, when earlier it was less than 1%. And the younger children and neonates are also being affected, and even vertical transmission is being recorded. And the spread in children is from the adults, because they are not being isolated, and the vaccination had been haphazard till recent times. So all these are causing concerns. But overall, as Dr. Kulkarni was also mentioning, the children are less affected, like they are being more of asymptomatic, and mild disease is being seen in them because of some factors, as all of us know. Lesser primary target receptors, the ACE2 receptors are lesser, more found in the GIT. So they are having more of gastrointestinal symptoms. And the strong innate immune response is helping them. And also the live vaccines are giving them secondary immunity, and the frequent viral infections that they get through their early years is also giving them some immunity, and lesser comorbidities is a very important factor. So these are the second wave lessons that we have learned. And so we are trying to gear ourselves up for the third wave, where more children may be affected. All these are causing concerns. And as family physicians and primary care physicians, we have to keep ourselves updated and learn things from day-to-day experience, from our own experience and the other specialists' experience, so that we can gear up and save our children before and address the third wave very confidently. So short this thing on the COVID disease progression. As we know, we had a confusion during the first wave when to give steroids. So many people were administering it in the first week itself and causing many problems. Now we have learned well that the first 5 to 7 days are the viremia phase, where the post-viral response will be immense, and that is the time when we have all the constitutional symptoms and all these things. And at that time, if you give steroids, it will cause it will prolong the viremic phase and viral replication will be increasing. So now we have learned our lesson and we are not giving it steroids in the first phase. So this is the viremic phase, which is timelines are like 5 to 7 days, and the pulmonary phase follows the viremic phase, goes on to the hyperinflammatory phase. So the treatment also will be according to the phase and the symptoms that we perceive. So this is the pathophysiology. You can see the respiratory failure, the hypercoagulable state, and the cytokine storm, which is following these timelines. The same thing you can see here. The pulmonary phase has a L type and H type, early L type and a late H type of elastance, where in the early L type we'll have more of a hyperinflammation, and in the H type we can have ARDS. So, and in the hyperinflammatory phase, you can have the cytokine storm and the macrophage activation syndrome, where the dysregulatory immune response is seen over there. And the post-COVID state, you can have lung disease and other organs also being affected. So if we go to the common symptoms that we see in children, usually the first thing we notice is the bouncing active child becomes very dull. He doesn't eat food properly, doesn't interact with the parents or with the friends, and just lying down listlessly without interest in anything. That's the first complaint the parents make, that he is looking abnormal. He's not his own self. He's not the active person that we know. So that's the first complaint that they make. And so they are always sleeping, or they feel weak, they don't eat properly. Then they may have fever with chills and sore throat, running nose, and sometimes swollen lymph nodes. And as the disease progresses, there may be rapid respiratory rate and heart rate. And most importantly, gastrointestinal symptoms are seen more in children because of the ACE2 inhibitor, ACE2 in the GIT. So they have diarrhea, vomiting, and abdominal pain. And in the severe cases, you can see severe abdominal pain, which is a pathognomonic sign. And then the poor feeding in an infant, and as I mentioned, taste of smell also can be seen in more than 8 years of age. Along with that, the skin manifestations and mucositis. And sometimes the child may be only majorly asymptomatic, but there may be an exposure to a household contact, a parent or a helper coming from outside. And in some cases, it will be just a passing viral illness. Like any other viral illness, not many of these symptoms can be seen. So the same thing, if you see in this diagram, extrapulmonary involvement with percentages, you can see that the multi-system involvement is more than 20%. Gastrointestinal is the highest incidence, more than 32%. Next comes the cardiovascular and the neurological, followed by the renal and cutaneous. So when do we really test for the children? When should we go for a COVID test? In all the suspected cases, like if we suspect that the child is exposed to some COVID contact, and the child's symptoms are going, any fever during this period, we have to first suspect COVID only. So that's why all suspect cases are to be tested. And as soon as possible after onset of symptoms, don't wait for 4 days or 5 days. So as soon as the symptoms occur, you have to go for a test. And if they are going for any other procedure, any other hospitalization other than COVID, then also you have to test the child. And even mild illness in a comorbid situation also, we have to go for a test. But there are some situations where, like we had a case where the father went out for a function and he came home with COVID infection. He was admitted in a quarantine center. Then later his wife had symptoms and she got tested herself and she was positive. So all the 3 children were tested. Out of the 3, one child, second child was infected. He was positive. But the elder child didn't have much symptoms, just a mild cold. But still, he was assumed to be COVID positive, and he was on home isolation, and supportive care was given. So that's the last point, that other asymptomatic contacts and children with mild symptoms with a known positive family member, they need not be tested. Actually, they didn't test the elder child and the youngest, but they were treated as COVID only because they may be assumed to be COVID positive and isolated and managed as per guidelines. And what are the tests to be done? Still, the gold standard is the RT-PCR test only. If it is not available, then you can go for a rapid antigen test. If it is positive, well and good. But if it is negative, you again have to go for RT-PCR only. So in RT-PCR, again, expert and TrueNat give faster results. And if the child is going into multi-system involvement, then we have to go for an antibody test also. But here we have to note that if the RT-PCR is negative, we may have to repeat it and evaluate for other illnesses also. But if the symptoms are protracted and RT-PCR is negative, but the inflammatory markers are increasing, then you have to go for a CT test for confirmation. But if no other diagnosis is there, you can't come to any other diagnosis, then you can assume it to be COVID and treat it as COVID only. So according to the symptoms and signs, we can classify the disease into mild, moderate, and severe. In this mild one, where the child will have only constitutional symptoms without any fast breathing, like fever, sore throat, running nose, cough, and dry cough, and diarrhea and vomiting. Here, the family physician and primary care doctor's importance increases, because this is the time where we have to give confidence to the parent, give some education so that she can monitor the child properly and have a home isolation with very few morbidity. But the parent has to be trained so that she can recognize the danger signs. So this part is very important for the primary care physician involvement. And in the moderate cases, pneumonia is can be diagnosed by fast breathing, where the respiratory rate is above 60 per minute in less than 2-month-old, and more than 50 in 2 to 12-month-old, and more than 40 in 1 to 5 years old, and more than 30 in more than 5-year-old child. There is pneumonia in this moderate case, but it's not severe. Like the respiratory effort is not much. So this moderate pneumonia also will need hospitalization and care. And that then the severe pneumonia will be seen as severe disease, where ARDS, sepsis, septic shock, and multi-organ dysfunction syndrome are seen. And the pneumonia can be, the severity of the pneumonia can be assessed by cyanosis, and the saturation falling below 90%, and the respiratory efforts are increasing, shown by grunting and severe retractions. And as the oxygen to the brain is being decreased, the lethargy, somnolence, and seizures can be seen. And as already mentioned, severe diarrhea, vomitings, and severe pain abdomen are seen in this severe case. So when we go to the step-by-step for the mild disease, as I told already, the home isolation is the key over here. But how do you know that home isolation is enough for these children? Some criteria are there, like the respiratory rate is below the age-specific criteria that I mentioned before, and the room air saturation is more than 94%, and there are no comorbidities. So these are the criteria for home isolation. And some social criteria are also to be taken into consideration, like the house is well equipped for quarantine for the child and the parents, and there is a caretaker to look after the child 24/7, and the one who can monitor the child's symptoms and signs, and if necessary, get back to us if there is anything going wrong. And when do we go for a hospital care, even in the mild diseases? When the house is too small, or there is overcrowding, or there is a high risk at home, or there are comorbidities in the child who is immunocompromised. Then we'll have to go for a child-friendly environment where the parent can accompany the child with a PPE and precautions. So how do we manage mild disease? It is through home isolation, supportive care, symptomatic treatment, adequate hydration and proper nutrition, and keeping the parents calm and the child also calm. And the masking, earlier it was about 3 years. Now the recommendations have changed to about 2 years. And when they are sleeping, we shouldn't use the mask, as there is a risk of choking in smaller children and also while sleeping. So you avoid the mask while the child is sleeping. And here the counseling and reassurance by the family physician and primary care physician is the key to the keeping everything in control. So the symptomatic treatment goes only like paracetamol 10 to 15 mg per kg per dose every 4 to 6 hours or SOS, and NSAIDs are to be avoided. The throat can be lubricated with warm gargles and warm water and honey in older children. Antibiotics are not indicated at this stage. And we have to train the caretaker in monitoring at home. Like earlier, we used to tell them how to keep a temperature chart. In the same manner, we have to ask them to tabulate these findings: respiratory rate per minute, temperature, pulse rate per minute, the nasal flare and chest retractions, gastrointestinal symptoms, sleep pattern, activity, and all these things should be tabulated and recorded at least thrice daily. And anything going wrong has to be reported to the nearest physician. And when should they seek hospital care is anything abnormal in this monitoring, like breathing difficulty, rapid respiratory rate, chest indrawing, nasal flare, cyanosis, reduced activity, lethargy, rashes, poor feeding, altered sensorium, seizures, and most importantly, saturation going below 94%. So this is going into moderate disease. As mentioned earlier, the criteria for moderate disease is fast breathing, age-based, and hypoxia 90 to 94% at room air, and pneumonia with no signs of severe disease like grunting and severe retractions. So then how do we manage the moderate disease? We admit the child in a COVID care center and monitor the progress. Here the family physician also can manage these cases, because even in our place, family physicians are playing a great role even in a hospital setup, but they have to be backed up by a pediatrician. That's a better thing, because if it's going beyond our control, we'll have a backup of a pediatrician also. Here we have to keep the inflammatory markers, a track of the inflammatory markers, and repeat them every 48 to 72 hours to assess the progression of the disease. And oxygen supplementation should be given to maintain the saturation at 94%, and proper hydration if necessary, IV fluids if the urine output is not 3 ml per hour. And then feeds, nutritious diet has to be given, protein-rich foods and vitamin-rich foods. And paracetamol as fever, to control fever if it is there beyond 100 degrees Fahrenheit. And if the child is developing wheezing also in addition to the sore throat, we can go for inhaled bronchodilators, but never nebulization, because the aerosol transmission is very high with nebulization. And the antibiotics only if clinical suspicion of bacterial infection is there, we can go for antibiotics. And systemic steroids at this stage are advised only if the saturation is not being maintained beyond 94%. So before shifting the child to an ICU, we can start systemic steroids, but only if the saturation is going beyond 94%. Then when do we refer to a higher center? That is, as mentioned earlier, or the inflammatory markers, if they are abnormal, like the case is going, COVID is actually a disease of thromboinflammatory this thing. That's why all the parameters have to be seen time to time, and this is that way we have to decide the treatment. So all the inflammatory markers have to be assessed, and if they are high and abnormal, we have to shift the child. And if increased work of breathing, that is, it's going into severe pneumonia, or there is hemodynamic instability and hypotension and shock are developing, and the increased oxygen requirement, in spite of the oxygen supplementation that we are giving, if it's the saturation is not being maintained at 94%, we have definitely to shift the child to a higher center. So what is the severe or critical disease? How do we define it? It is severe pneumonia with cyanosis, saturation less than 90%, and increased respiratory effort. And as earlier mentioned, the oxygenation to the brain is being compromised. So lethargy, seizures, and somnolence are also noticed. And severe diarrhea, vomiting, and abdominal pain are the symptoms mostly seen in children. This critical disease is a subset of the severe disease where it's going on to sepsis, ARDS, shock, and multi-organ dysfunction syndrome, and acute thrombosis. As mentioned earlier, it is a thromboinflammatory phenomenon. So all these things will happen. And depending on these things, we have to plan our management also. So what do we do in a severe disease? We have to admit in a high dependency unit or ICU and evaluate for thrombosis, HLH, and organ failure. So accordingly, we do the investigations for the thrombosis and the inflammatory markers, and each organ failure like the LFT, RFT, and all these things, and the heart also with troponin and and LDH also has to be done. And every 24 to 48 hours, we have to keep assessing to see how the disease is progressing. And the target oxygen saturation has to be maintained at 94% as before. But here we will be using nasal prongs, facial mask, high frequency nasal cannula, NIV, or a non-rebreathing mask, depending on the requirement of the oxygen that we have to give the person. Then the restrictive fluid therapy, like here it may go into myocardial dysfunction. So we have to be very careful with the fluid therapy. And prone posturing, we have seen that it's increasing the saturation by 10 to 20%. So it's an important thing that we have to do in an ICU setting. Even if the ICU is not readily available, even in a lower center, we have to do this prone posturing. And because the ICU is we may get infection from the ICU, iatrogenic infection. So we have to have empirical antimicrobials also to be given. And systemic steroids are mandatory now. And if it's before 10 days, then the antiviral also has to be planned. Remdesivir is the one that we are doing. And the anticoagulants for the thrombotic thing, we have to have a prophylactic anticoagulant therapy also. So what do we do for the critical disease? Critical disease, as we have seen, is acute respiratory distress syndrome or shock. So in ARDS, it can be divided into mild ARDS, severe ARDS, and poor response. In milder one, we have to go for high frequency nasal oxygen or NIV trial. And severe ARDS, we go for a mechanical ventilation. And if there is very poor response, we may have to go for ECMO also. And in shock, it is septic shock with myocardial dysfunction. So we have to give bolus IV fluids, 10 to 20 ml per kg over 30 to 60 minutes. If it's hypotensive, we may have to give a faster thing. But we have to be very cautious here because we may cause myocardial dysfunction if we are too anxious. And we have to go for inotrope support and monitor the fluid overload very cautiously. And we have to manage the acute kidney injury or HLH or myocarditis according to the protocols. So what are the drugs used in a hospital stay? There are four groups like antivirals, steroids, antimicrobials, and anticoagulants. So all these four groups, we can go for the doses accordingly. And another entity that I want to stress upon is the COVID in neonates, which we are seeing nowadays. The early onset, late on.
Dr. Nalini, just a minute.
Yes.
Before we go on to that,
yes.
For the participants, if you have any questions, please put it in the chat box as we are going with the presentation. So over to you, Dr. Nalini. Sorry for the interruption.
This entity of neonates also has to be taken into consideration. So generally, the neonates can acquire COVID-19 during delivery or during the postnatal period. A few cases of vertical transmission are also being reported nowadays. So it could be early onset or late onset, or rarely it's a multisystem inflammation syndrome in neonates, like MIS-N also is there. So majority are preventable and majority no symptoms, or they have only mild illness, and it's a very good prognosis is seen till now. So what do we do for the neonate is earlier we used to have them in separate rooms, but now the recommendation is we can have rooming in of the child and mother, but with a distance of 6 feet, and breastfeeding must continue. with hand hygiene and breast hygiene, and demand feeds because these antibodies can prevent the child from other illnesses, and that way the child will be safe. And if the low birth weight babies are there, we can go even for kangaroo mother care with all precautions. And the routine immunization has to continue. So again, I stress upon keys to protection as minimal handling, universal masking, physical distancing, respiratory etiquette, hand hygiene, breast hygiene, and a very good housekeeping to prevent all types of infection. So important complication, like that uncommon complication, but a very important complication of coronavirus is the multisystem inflammatory syndrome in children, that is MISC, which can cause Kawasaki-like illness or toxic shock syndrome. So though it is uncommon, it is frightening and it needs a very intense care in a ICU. The child may also go on to a ventilator for many days. So what are the criteria that WHO has given? First one is children and adolescents 0 to 19 years with fever more than 3 days. And any two of the following of the 5 features. One is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammatory signs of mouth, hands and feet, or hypotension or shock, or features of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities like dilatation and aneurysms. All these can be seen by the rapid heart rate or murmurs or cardiac tamponade or chest pain or anything. And evidence of coagulopathy by PT, APTT, and D-dimer reports. And acute gastrointestinal problems like earlier mentioned as diarrhea, vomiting, and severe pain abdomen. And increased inflammatory markers are another criteria, such as ESR, CRP, and procalcitonin. And if even there is no other obvious cause of inflammation or bacterial sepsis, this is also one criteria. And evidence of COVID-19, the last criteria, which can be by RT-PCR or antigen or the antibodies. Or most importantly, likely contact is also an important criteria. So what is the pathophysiology of MISC? It is not completely understood even now. But we can say that it is diagnosed in children with previous infection, like some 4 to 6 weeks back or even 2 months back, or they give a history of some death in the family due to COVID, or a family member was severely infected with COVID, and this child might have been asymptomatic at that time. But now after 1 or 6 weeks or 8 weeks, she presents with a severe MISC. And it could be also be active infection. So we have seen children from our patients also, like the grandmother expired on ventilator when she was on ventilator, and later after 2 months this child had to be hospitalized because of the respiratory efforts and the rashes and all these things. But luckily she came out of it, but they lost the grandmother. So the incidence we can see like 12 cases per 1 lakh population, very small, but nowadays it's increasing. And actually Dr. Suhass has seen almost 15 cases, but all of them are good now. No mortality has been seen. So he'll elaborate it in the question answer session. And what is the possible mechanism of this MISC? It could be immune dysregulation, antibody enhancement, or T-cell mediated damage or enhancement of inflammation. These are the possible mechanisms that is causing the havoc. And the clinical spectrum can be seen as 3 classes. Class 1 is hyperinflammation with multi-organ dysfunction syndrome, where more than 6 organs are affected, and there is a cytokine storm. And the second class is of respiratory ARDS and myocarditis. Here the RT-PCR is positive in 84% of cases. And class 3 is age is more than 6 years, but they have Kawasaki-like disease and atypical Kawasaki disease also, where the serology may be 63% positive. In some cases, we have both serology and RT-PCR positive. And the mortality varies according to the classes. Some more studies have to come from India to classify these things and record the mortality rate. So these are the signs of MISC that you can see: the strawberry tongue, the conjunctivitis, extremities almost going to blue, and the hyper swelling also, and the bluish discoloration of the nails and the rashes. And these are the systems that are infected according to percentage. We can say left ventricle dysfunction is 100%. Bulbar conjunctivitis is 89%. Cervical and mesenteric lymphadenitis is 60%. That could be the cause of the severe abdominal pain that they complain of. And red and cracked lips is 54%. Digestive involvement is 83%. Respiratory 34% and neurological 31%. So accordingly, the symptoms will manifest, and so we can be aware of the left ventricular dysfunction and digestive involvement and cervical mesenteries and conjunctivitis. Here you can see coronary dilatation, which is the dreaded one, is almost 17%, with pericarditis as at 8%. So these are all the, we have to keep in mind all these systemic illness that is going to manifest. So how are we to go about the lab? So the to be interpreted with the clinical course and treatment received. It is not just the lab results that we treat. We have to go by clinical assessment and see what the treatment was given and how the child is responding. We don't treat the results, we treat the child only. So as a general rule, 3 to 6 times rise from baseline is very significant. And you can see the neutrophil lymphocyte ratio is increasing. CRP is more than 100 and rising. Ferritin can go beyond 700 and rising still. And D-dimer can be more than 1. And LDH is more than 400. And IL-6, this is not very reliable, but because of the difficulty in taking the sample and all, but still, if it is done, more than 80 and rising is significant. So how do we manage MIS in a tertiary care? I don't dwell much upon this because the other speakers may give their experience because they have been treating MIS in tertiary care. But overall, we can say that we can divide the treatment according to no shock and no coronary dilatation, and Kawasaki disease shock or toxic shock syndrome, and multisystem involvement and severe myocarditis and coronary involvement. The third group will be toxic shock syndrome, like classical MIS in older children. And in shock or no shock, the main treatment is with intravenous immunoglobulins, methylprednisolone and aspirin. And if there is a refractory KD shock, we have to consider tocilizumab also. And according to Dr. Suhass, these have been giving very good results. So he will elaborate upon it. But here in tocilizumab, we have to be very cautious because it's an immunomodulator and it may decrease the immunity further. And the platelet count may decrease to 50,000 and INR may go up to 500 also. That has to be kept in mind when we go for tocilizumab. Though it is only a single dose medicine, it can cause so many complications. And then the toxic shock syndrome, we have to go for a fluid bolus and early vasopressors along with the immunoglobulin and methylprednisolone. Here we have to go for low molecular heparin also and tocilizumab appropriately. In all these situations, we shouldn't forget about the respiratory support that is to be given with oxygen by non-rebreathing mask or HFNC, high frequency nasal cannula with 15 liters of oxygen. This should be there along with the other treatment. So as I was mentioning that in Europe and other countries, we have been seeing so many reports and so many case studies and so many studies that are educating people. But here, unfortunately, we are not having much of a study still. Maybe because the erratic reporting, or maybe that we are still not into studies. But still, I wanted to share with you a small study from North India, where in February 21, it was reported in Journal of Tropical Pediatrics, where they studied some 40 COVID children, where 20 were having MIS-C criteria. These are the percentages of the symptoms that have been seen. And many more such studies are needed in India also for us to understand the disease and go into the consequences that the children may face further. And the CDC data given recently on May 3rd you can see the MISC patients are more than 3,400, 3,740, and the deaths are only 35. Now, all through the disease process, we can see that because of the media or the family being affected directly or indirectly, seeing other relatives dying or friends dying, all this is causing so much panic in children and adults together. So that is playing havoc on the psychological mind of the children, on the minds of the children.
Correct. So
we have
Nalini,
to see this. Yes, I'm almost done, sir.
Yeah, because there's going to be a panic for the questions.
Just one more slide, sir. This is the last slide.
Thank you.
The psychological problems in children during the pandemic, we can see, depending on the stress that they have to go through because of the disease that they're having, or the home isolation or the confinement to four walls that is causing so much havoc, and they're behaving erratically and showing temper tantrums, quarreling with their parents, all mood swings and all this because of confinement. That we have to understand and ask the parents to keep calm and give them a plan, like routine at home with playtime, fun time, meal time, exercise time. The whole family together, they have to enjoy their togetherness, and we have to help children pick up hobbies, and parents should become role models for activities, handling stress and having proper hygiene and everything. Whatever we preach, we have to practice and show them. And we have to avoid excess information about disease and death. And we can have video calls with near and dear to share the activities. So here I want to stress again upon the role of the family physician and primary care physicians when we are going to may encounter a third wave, because the virus is so unpredictable that every day is becoming a learning. So even the third wave, it may or may not affect the children in high numbers, but still we can't predict. So we have to be cautious and we have to keep ourselves updated and learn from our own experiences and others' experiences. That way the family physicians and primary care physicians have to play a very major role. Otherwise, as H.W. Longfellow has said, what would the world be to us if the children were no more? Imagine a world without children. And children are not to become history. They have to make history. So that way, Nelson Mandela had said that history will judge us by the difference we make in the everyday lives of children. So ending on this note of Charles Dickens, have a heart that never hardens, and a temper that never tires, and a touch that never hurts. So thank you, AFPI CPD, for giving me this opportunity. And thank you for Suhass, who accepted my invitation to be a co-speaker. And Dr. Kulkarni, we are waiting for your valuable words. And Dr. Kamlesh, again, thank you very much for this opportunity. Thank you, sir.
So thank you very much, Dr. Nalini. Very comprehensive and very interesting. But in view of time, let's go over to the questions. We have quite a few questions on the chat box.